Good afternoon. Hello there. This is Michael Lipinski with ONC. Thank you for joining us today. We're going to conduct a webinar on information blocking, particularly focused on our recently issued frequently asked questions. We'll also discuss some important dates and events today, and as well as our future approach to information blocking guidance and education. And then please stay tuned to the end when we will just take questions from the audience. I want to remind everyone that this presentation is being recorded and the slides and recordings will be available on our website about a few days after this presentation. And you'll be able to find that at healthit.gov/cures rule. Okay, again, I just wanted to give a little time for more folks to join. And we're going to get ready to dive right in here. And okay, let's get started so we make sure we have sufficient time for questions. So today, again, it's Michael Lipinski. I'm the Division Director for our Regulatory and Policy Affairs Division. That's within the Office of Policy here at ONC. I'm joined today by my colleagues, Rachel Nelson, who's a branch chief in our Compliance and Administration branch, which is in the Regulatory and Policy Affairs Division, and Cassie Weaver, who is a policy analyst, again, in the Compliance and Administration branch and part of the Regulatory and Policy Affairs Division. Let us go to the next slide. So you'll see this on a lot of our presentations. I guess you can call it a disclaimer, but it's really just for awareness. So we do our best here today to give you accurate representations of both the law and regulations and even the FAQs that we'll be discussing today. But again, it's not the official program requirements, and those are contained in the relevant laws and regulations, which you'll find in parts 170 and 171 of Title 45 of the Code of Federal Regulations. Let's move to the next slide. Okay, so a little bit of background on our approach to information blocking and just generally what is in the cures rule. So right now you can find on www.healthit.gov/cures rule all information related to the cures rule and information blocking. We will be transitioning to a web page focused just on information blocking. So we're trying to aggregate all the information all the information that supports information blocking in one place. So that'll be, so you'll probably see a change to the URL in the near future. So stay on the lookout for that. But for as of now, you want to go to the link provided on the screen. So we've provided fact sheets when we issued the final rule, and we're actually continuing to develop fact sheets. There'll be a fact sheet focused on health IT developers that participate in the ONC Health IT certification program, and therefore are developers of certified health IT under the information blocking regulations. So look out for that. We are continually working on technical assistance and guides. So we're working with stakeholders to produce those. And to that point, on the next bullet you see on your screen, we are working, for example, now with certain stakeholders to produce a continuing medical education approved presentation on information blocking. And we're also working with our stakeholders on some of the educational resources they are developing for their memberships. We're going to continue to do webinars as well. You can request a webinar for your association or organization. You want to do that through the ONC speaker request form. And we'll be glad to review that. And if we have staff available, obviously participate in that webinar for you. Obviously, there's media and press as well that we do, that those are associated usually with like the rulemakings, or for example, when we issued these FAQs, we sent that out on our listserv, and I'll talk a little bit more about that on an upcoming slide. The Health IT Buzz blog is another place you want to go to find information right before the holidays. Our Deputy National Coordinator, Steve Posnack, issued a blog post related to information blocking. So I encourage you to go there, look those up and read those. And then very importantly, we have the Health IT feedback and inquiry portal. So that is if you have specific questions, and I'll show you that on the upcoming slide, just so you have a reference point, what you're looking for on our website to do this. But you submit your questions there. That helps in terms of tracking. It also helps lead to us getting like issuing these FAQs where we see there's a theme regarding questions or possibly some confusion regarding the information blocking, and then we can focus more on those and issue as we did FAQs, or independently respond to you if we can on your specific question. Let's move to the next slide, please. So there you have it, the healthit.gov feedback webpage. You can see you can make various inquiries here. So not just about the cures rule and information blocking, but if you have if you want to report information blocking, there's a way to do that. And questions about other specific topics are listed there, as you can see. So I encourage you again to go there if you have questions. And if to that point, if your question isn't answered today, I highly recommend you go to this webpage and submit your question there as well. Let's move to the next slide. So this slide is just, I mean, I'm sure you've seen it on if you've participated in any of other webinars, to give you contact information. The key points here, again, you see the feedback web link, but also if you want to follow us, like on Twitter. So when we issued these FAQs on last Friday, again, Steve Posnick, our Deputy National Coordinator, was tweeting out about these FAQs. So it's a way to get the most recent information that we're releasing, whether it's information blocking or any other policy concerning ONC. So you can follow us there. You can connect with us on LinkedIn. And then at the bottom of the screen, you can see there, you can subscribe to our listserv. So anything that we're doing goes out on our listserv, whether it's a webinar, whether it's a new report, whether it's the rule that we've issued, whether we have an upcoming, our annual conference. So I strongly encourage you to sign up for our listserv. So let's move to the next slide. Start to get into a bit of the meat of the presentation. So information blocking definition. I think it's a good opportunity to talk about what ONC's role was with information blocking. So Congress, in a unbelievable, I would say, bipartisan way, passed the Cures Act. It was, I don't have the numbers in front of me, but I remember it being only a few members of both houses of Congress did not vote for the legislation. So it was strongly bipartisan. In it, it had the definition of information blocking besides paragraph B, which you see on the screen. And so it was our job actually to look at the current market and determine, and that includes, the laws that were applicable to those covered by information blocking, to determine what were reasonable and necessary activities that should be continued to be promoted and protected under information blocking. So our primary focus with this regulation was to identify those, and we've identified 8 exceptions. And I think a key point to be made, it was looking at the market as it is today. So we don't see those exceptions as stagnant, that they couldn't be revised. And to that point, we even talk about, and we'll get to this in the next slide, the EHI definition is as a point of time. And actually how we approached complying with the EHI definition was from a point in time. And that we focused, and when we get there, we'll talk about the data elements represented by the USCDI. And that's what you see. That's, one of the steps we took with the definition here in paragraph B, and we'll talk a little bit more about that on the next slide. But it's really important to understand that Congress, it's been now over 4 years, passed a law that said that essentially what you see there, that you should not interfere with access, exchange, or use of EHI if you're covered by the information blocking statute and regulation. So let's move to the next slide. Talk a little bit about the applicability date. So we issued back in November, early November, right before November 2nd, an interim final rule. And that interim final rule moved the applicability date of information blocking from November 2nd of 2020 to April 5th, 2021, which is only a little more than 2 months from now. It also then accordingly also pushed out the content and manner exception compliance with it and the definition of EHI as you see here on the screen. So from April 5th to October 6th, 2020 to actors covered by the information blocking regulation need to make available the data that is represented by the US CDI. And we were clear in the reg and the preamble what we mean by represented. It doesn't mean the standards that are associated with the data elements found in the US CDI. It's the data so for example, it's demographics. So if you have demographics data in electronic format, so, you know, the name of the race, the name of a patient, that's the data we're talking about. It doesn't have to be coded to, for example, with race and ethnicity, to the OMB standard or to the CDC standards there. If you have that data, you should be making it available. And we've issued some more FAQs on this back when we issued the interim final rule, and just more recently describing EHI, what it is, you know, the scope of EHI. So I encourage you to look back at the rule and at the FAQs on our website that talk about EHI. A really important point I want to make about the date you see on the screen, and that's April 5th, besides the fact that it's in 2 months, it was done through an interim final rule. And for those that aren't intimately familiar with interim final rules or more familiar with interim final rules issued by CMS under Medicare, I wanted to make clear a couple points. One is we are not required to issue a final rule for this interim final rule. Under Medicare, CMS has to issue a final rule. So you should not expect or anticipate a final rule for this interim final rule we issued back in November. And the other key point is it is final. So that April 5th date is the date for information blocking. And again, you should not anticipate or expect a final rule to be issued that would be changing anything at this point in time. The department always retains a discretion to do so, but I wanted to make sure from an expectation perspective, it's that everybody who's listening today understands what an interim final rule is. It's not like a notice of proposed rulemaking. We didn't come out and say, we propose to change the date to April 5th and then took comment, and then we're going to issue a final rule that you either keeps that date or changes the date to a different date. It sets the new date from November 2nd to now April 5th. So that is the date of compliance anyone covered by the information blocking regulation is looking at. There's a couple points on interest here. Maybe as I was talking, you caught those on the screen about, you know, you don't have to provide all EHI, but EHI also is not just from the date of April 5th on. And we have an FAQ that talks about that. It's EHI that you have. And we'll talk, and my colleagues will talk a little bit about technology and you know, how that plays into information blocking. And that's what a couple of our FAQs were designed to address. And I'll let them talk a little more about that. And we'll also be talking about the preventing harm exception as well. So at this point, I think we can transition to the next slide and talk about the information on that slide. So compliance enforcement, I think I've hopefully driven that home, but again, April 5th is the applicability date. And so from a compliance perspective, developers of certified health IT will be accountable for the information blocking condition of certification on that date. As you can see on the screen, that's found in 45 CFR 170.401. So ONC would have the ability, if we received a complaint on April 5th, alleging information blocking against a developer certified health IT to take action at that time on that complaint. Civil monetary penalties switching to. So the broader enforcement is done by HHS's Office of Inspector General, and they have the ability to issue, to investigate all actors covered under the information blocking regulation. And to remind you again, those are developers of certified health IT, health information networks, and health information exchanges, which we have defined the same in regulation. And then lastly, healthcare providers, which is a very broad definition. And we'll talk a little bit about that definition before we jump into each specific FAQ. But again, come April 5th, OIG will have the ability to investigate claims of information blocking. But what they've said about enforcement is they will exercise discretion not to take any enforcement action until they issue their final rule for civil monetary penalties, which they have not done yet. They issued a proposed rule in the middle of last year, and they have not yet issued a final rule. And then for providers, there still needs to be rulemaking done by the department to establish disincentives. So let's move to the next slide. Okay, so we're about to talk about the FAQs that we issued in January. There were 13 FAQs issued. We have a total of 32 FAQs on our website. These FAQs are categorized by topic. So you can find them discussing actors, discussing EHI, electronic health information, discussing the concepts of interference, as well as all our exceptions, both generally and now with these most recent FAQs, we have FAQs on the preventing harm exception, which we'll discuss today. We issued 13 FAQs in January. We're going to discuss 10 specifically. And the 3 that we won't be talking about are related to EHI. I again encourage you to go to our website and look at those FAQs on the scope of electronic health information. The ones we most recently issued talked about draft clinical information, talked about the scope of notes. So again, I encourage you to go look at those 3 FAQs, but we won't be talking about them in detail today unless they come up as a question at the end here. So I think the other main point I want to make here is FAQs are broad. They're intended to cover a broad range of either subject or practice, or particularly those actors covered by the rule. So please keep that in mind when you think about how this would apply. We're not looking specifically, for example, at healthcare providers that participate in, say, CMS's promoting interoperability program. When we issue an FAQ, we have to consider that it has to apply to pharmacists. It has to apply to providers practicing in long-term and post-acute care settings, that apply to labs, that apply to pharmacists and pharmacies. Those are all covered under the information blocking regulation. So when we're looking at issuing a broad scope interpretive guidance, we have to consider everyone that's affected by that. So wanted to make that that awareness for everyone and understand, you know, a bit of how we look at issuing these type of guidance. And so with that, I'm going to turn it over to my colleague Cassie, and she's going to talk about the first 5 FAQs today. So Cassie.
Hi, everyone. Could you go to the next slide, please? I'm going to jump right in to try to leave as much time as possible for my colleague speaking after me and for you all to have the chance to ask some questions at the end. So the first FAQ I'll address is this. Do the information blocking regulations require actors to have or use certified health IT, or to upgrade the certified health IT they already have in order to fulfill a request to access, exchange, or use EHI? In short, no. Actors are not required to use certified health IT to fulfill a request to access, exchange, or use EHI. And if an actor does use certified health IT, they're not required to immediately upgrade that certified health IT if they also happen to participate in a separate regulatory program that requires the use of certified health IT. For example, CMS is promoting interoperability programs. And on our website, we have a couple of other related questions, which ask if the information blocking regulations are applicable to healthcare providers who don't use certified health IT. And that answer is yes. If you're a healthcare provider as defined in the information blocking regulations and by statute, then you're considered an actor and subject to the regulations, even if you don't use certified health IT. It's the same answer for health information networks, health information exchanges. If any entity or person falls within the definition of actor, then that person or entity is subject to the information blocking regulations, regardless of the health IT that is used. So, as Mike mentioned earlier, the scope of the EHI is limited to the data elements represented by the US CDI. So this isn't a requirement to use a specific transport method or standard or any particular technology, certified or not, to provide the access, exchange, or use of EHI. It is agnostic to that. If you are an actor, you are covered. So let's go ahead and go to the next slide. And I'm going to move into the interference topic here. So with that sort of general question out of the way, let's talk about interference, which is a key word in that information blocking definition. Information blocking is a practice that is likely to interfere with the access, exchange, or use of EHI. And this is a good point for me to remind you that while I'm going through these questions, just because I say something may be an interference, that's not to say it's automatically information blocking. Interference is just one element, right? Because the definition of information blocking is that it's a practice that, except as required by law or covered by an exception, is likely to interfere with the access, exchange, or use of EHI. And if the practice is conducted by a healthcare provider, it can only be information blocking if the provider knows the practice is unreasonable and knows it is likely to interfere with the access, exchange, or use of EHI. Now, if the actor is a health IT developer of certified health technology or a health information network or exchange, that standard's a little bit broader and covers practices that the developer or network or exchange knows or should know is likely to interfere. But if the actor is a healthcare provider, it's only information blocking if the provider knows the practice is unreasonable and knows it's likely to interfere. And even after all that, if you've satisfied all of these elements, an exception could still apply, which would mean that it would not be information blocking. So this first interference question, do the information blocking regulations require actors to proactively make EHI available through patient portals, APIs, or other health IT technology? No. The answer is no. There isn't a requirement in the information blocking regulation that says actors must proactively make EHI available to patients or anyone else who hasn't requested it. But a delay in the release or availability of EHI once a request has been made may be an interference under the information blocking regulations. And remember, if the delay is an interference, it still may satisfy an exception or other things that would take it outside of information blocking. This is just the one interference element. So in some circumstances, a delay in the release of results could possibly meet all of the conditions of the preventing harm exception, for example, which my colleague Rachel will be talking about after I'm done with these. in the next half of the webinar. So the reason we ended up at this point with the proactive, with there not being a proactive requirement, is because these regulations are applicable to all actors. And as Mike was saying, those are really broad categories. So if there was a policy that EHI be proactively shared, then it would apply to provider requests as well. And all sorts of these scenarios that would make it really odd to have to proactively share information before a request is made. So can we go to the next slide, please? Okay, so this question and the one I just discussed go hand in hand, and we are aware there's been confusion about this, so I'm happy to be here to help clear some of this up. Here's this question. Are actors, for example, healthcare providers, expected to release test results to patients through a patient portal or API as soon as the results are available to the ordering clinician? And one way to think about the answer here is to think of it as a question. Has a request been made? If so, then yes, those results should be provided as soon as they're available. Taken together with that previous FAQ, this will lead to situations where if a patient is using a portal or API to access their EHI already, then once the patient is logged in and clicks on test results, if those results are available, they should be there. This is not making the results proactively available. It's fulfilling that patient's request for EHI. So hopefully that explains some of the confusion. I can't see the Q&A. I'm sure lots of people are asking what exactly constitutes a request, which can be a really fact-based question and very dependent on whatever situation you're discussing, but we know people want to hear more than that. And so I will tell you to stay tuned. This is just one part of an ongoing webinar series. And we have lots of other ways to get information to you all. So I can go further and say that if there is a general policy to withhold test results for some period of time, say 72 hours, before the results are made available to the patient, just as a general matter of policy, that's probably going to be an interference. The policy under all of this is that now there's an expectation that EHI is available when and where it's needed. So these generalized policies like that are going to be an interference unless you meet an exception or there is another element missing. And we know this is a big transition for folks who are ordering these tests for lots of people. But as a member of our clinical team here at ONC often reminds us, Congress passed this law because of the overwhelming good that's going to come from it. And while most of the examples I've given have been about patients requesting it, this applies to providers who are making these requests as well. A clinician requesting EHI from a lab, a health information exchange, or any other actor can also expect to have that information made available to them without interference, barring, again, any applicable exceptions. And our clinical team here at ONC talks to folks who work all over the country in all different kinds of health systems. And in places where this kind of change has been made, where there aren't these generalized policies of withholding test results, they're hearing really overwhelmingly positive feedback from patients and the ordering clinicians. So I just want to emphasize one last time that this is making EHI available upon request. It's the patient still has to go out and get their EHI, their test results. Okay, so I hope that that helps clear up some of the confusion. Can we go to the next slide, please? Okay, so this question is a very common inquiry we hear. When a state or federal law or regulation, like the HIPAA privacy rule, requires EHI be released by no later than a certain date after a request is made. Is it safe to assume that any practices that result in the requested EHI's release within that other required time frame will never be considered information blocking? No. The information blocking regulations have their own standalone provisions, and the fact that an actor is responsive within the time frame mandated by some other applicable law does not automatically mean that that practice does not implicate the definition of information blocking. So to put this another way, if there's a separate law that says, for example, CMS requiring a response within 36 hours, if a request has been made and an actor can respond sooner, it doesn't mean that the actor can just delay it for 35 hours and assume that so long as they're within 36 hours, the practice won't constitute an interference under the definition of information blocking. So responding within these other timeframes does not necessarily mean that the practice is not information blocking. Next slide, please. Okay. However, if state law requires a specific delay in the communication of EHI or requires that EHI be communicated to a patient in a particular way before that information is made available electronically to the patient, then no, that is not information blocking. The difference is that here there's a state law requiring the practice, whereas the previous scenario addressed the existence of some other permissible time frame. Here it's not information blocking because the definition of information blocking specifically says a practice that, except as required by law, interferes with the access, exchange, or use. So where it's required by law that it be delivered after a certain time period or in a certain way before being made available electronically, that's not interference and is not going to be information blocking. And that is important to keep in mind kind of across the board, that you have to, meet all of the elements of information blocking or all of the elements of an exception. And given the knowledge standards, it's not something providers can do accidentally. Providers have a standard of knowing that the practice is unreasonable. And I'm going to go ahead and stop there and hand it over to Rachel to discuss the preventing harm exception, which might answer some of the questions that you all still have. So.
Good afternoon, everyone. Next slide, please. In talking about the preventing harm exception, first of all, I want to say, just as a reminder and refresher, this exception provides that an actor's practice likely to interfere with the access, exchange, or use of electronic health information, specifically in order to prevent harm, will not be considered information blocking when the practice meets the exception's conditions. I want to encourage everyone that to assess whether any particular practice may be covered by the preventing harm exception, please review the full text of its condition and the preamble discussion of them in the CARES Act final rule. These FAQs do respond to numerous inquiries by presenting certain information from the rules preamble in a more user-friendly format. But the FAQs that we have posted at this point and that I'm going to talk about here today do not pull in all of the exceptions conditions or all of the considerations that we did talk about in the final rules preamble. And with no further ado, I will start with the first FAQ that we're going to talk about today. The information, I do want to pause here, and I apologize. For those of you who would like to raise questions, please use the Q&A feature of Zoom if you possibly can. That is the best place for us to capture and make sure that we have all of the questions that you're sending in to us today. We would really find it a lot easier if you did not try to do that in the chat function instead. And back to the first FAQ that I'm going to talk about, a lot of folks keep asking, do the preventing harm exception requirements for the type of harm align with the HIPAA rules? Yes, they do. In fact, the type of harm condition of this exception relies on the same types of harm that would serve as grounds for reviewable denial of an individual's right of access to their own information under the privacy rule. Again, the one thing I want to emphasize, we did put in a table, it's in the final rule itself, that maps particular circumstances to the applicable harm standards for this exception to apply. And these are, again, the same harm standards that would be used to deny access if an individual or their representative came in and asked for access to their protected health information under the HIPAA privacy rule right of access. There are, as many of you know, other provisions of the privacy rule, and some of those provisions, for example, where the privacy rule would allow for unconsented disclosure of particular information when necessary to prevent harm to someone or the public. The HIPAA rule would use a different harm standard for some of those provisions. This particular preventing harm provision that is parallel to denying someone access to their own health information uses the same standards, and that was something that was raised by public commenters on the proposed rule that encouraged us to align. And in the final rule, the preventing harm exception is very tightly and specifically aligned. Next slide, please. A lot of folks asked, will a preventing harm exception cover practices interfering with access, exchange, or use only if the harm is imminent? And the answer there is no. The reasonable belief condition does not include a requirement that the harm would be expected to occur in a particular time frame. We didn't invoke imminent or immediate within that condition. The condition just requires that an actor engaging in a practice likely to interfere with access, exchange, or use have a reasonable belief that the practice will substantially reduce a risk to the life or physical safety of the patient or another person that would otherwise arise from the affected access, exchange, or use, particularly when and that is the harm standard, I will say, for interfering with an individual's access to their own protected health information, their own electronic health information. Next slide, please. And again, the harm standards for the different situations, such as when a representative or a proxy, if you will, requests access to a patient's electronic health information, would map to the substantial harm standard in parallel, again, to the privacy rules grounds for denying individual access. And I am moving pretty fast here, but I do want to leave us time for open questions at the end. The next FAQ, and under the preventing harm exception, a lot of people have asked, would the preventing harm exception cover a blanket several-day delay on the release of laboratory or other test results to patients, so an ordering clinician can evaluate each result for potential risk of harm associated with the release? This is the FAQ that ties back to what Cassie was talking about with just choosing to hold information for some period of time being an interference. And the preventing harm exception will not cover a blanket delay of a broad array of information. It's designed to cover only practices that are no broader than necessary to reduce the risk of harm to the patient or another natural person. As you know, and as we discussed in the Cures Act final rule, a clinician generally orders tests, for example, in the context of a clinician-patient relationship. In the context of that relationship, the ordering clinician would know the range of results that could be returned on that test, and they could prospectively formulate, in the exercise of their professional judgment, an individualized determination for the specific patient that either withholding the results of the particular test from the patient would substantially reduce a risk to the patient's or another person's life or physical safety, or they could determine that withholding the results of the particular test from a representative of the patient would substantially reduce a risk of substantial harm to the patient or another person. And again, that difference there is who's asking. Is it the patient asking for their own electronic health information, and that connects to the physical harm standard, versus the representative of the patient asking for the patient's electronic health information, and that would require just the substantial harm standard be met. Now, this FAQ is a relatively long one, so next slide, please. Individualized determinations made in good faith by an ordering clinician in the exercise of their professional judgment and in the context of the treatment or clinician-patient relationship, if you will, within which they order the test, would satisfy the type of risk and type of harm conditions of the preventing harm exception. And another question we've gotten fairly often was, can other actors rely on one of these determinations if they didn't make it themselves? As we say in the FAQ, actors, including but not limited to the ordering clinician, could implement practices in reliance on the individualized determination made by the ordering clinician, and by that way satisfy the preventing harm exception reasonable conditions. And as we say here, the harm exception covers as long as the practices satisfy the other conditions of the exception as well. Next slide, please. So we got a lot of questions about whether the harm exception would cover interfering with a parent or legal guardian or other legal representatives' access, exchange, or use of a minor's electronic health information. And, where the patient, if it's done in order just to avoid breaching the patient's confidentiality and their trust with a provider, but the harm standard of the preventing harm exception is not met, then no, the preventing harm exception will not cover it. Only if the actor reasonably believes that the interfering practice will substantially reduce a risk of at least substantial harm to the patient or another person will the preventing harm exception cover. That's what it's designed to cover. And notice that because it would be the parent or the legal guardian requesting the information of the minor who is another human person, the harm standard that applies is substantial harm. Also note that when we're talking about the patient's confidentiality, their privacy preferences, the privacy exception does contain a sub-exception that covers practices respecting an individual's request not to share information, subject to conditions that are laid out in the privacy exception itself. Next slide, please. And I foreshadowed this a little bit in the prior slide and perhaps in the HIPAA alignment slides, but where we get this one a lot, where the patient is a minor and to reduce the risk of harm other than physical abuse, will the preventing harm exception cover an actor's practices interfering with a parent or legal guardian's access, exchange, or use of the minor's electronic health information? The answer is yes, where the risk of harm has been determined on an individualized basis and all other conditions of the preventing harm exception are met. For example, the practice must be no broader than necessary, and the actor must reasonably believe the practice will substantially reduce the risk of harm. For purposes of the preventing harm exception, a parent or legal guardian would be considered a patient's legal representative, and that leads us again to applying the substantial harm standard because it is the representative requesting access to the minor's electronic health information and not the minor requesting access to their own electronic health information. Next slide, please. And to emphasize again, there's a little across the FAQs, there is repetition of some points. And as we talked about earlier, the type of harm conditions for the harm exception are very specifically aligned to the HIPAA privacy rules grounds for reviewable denial of an individual's right of access. I would highly encourage people who want more depth on this to, when you visit the FAQs, notice that we've linked this FAQ to the preamble discussion, and also we've linked it to the table that I mentioned in the preamble of the final rule that maps which harm standard applies based on who's asking for whose information. And I believe that is the final FAQ for preventing harm that we were going to discuss today. But could we go to the next slide to confirm that, please?
Perfect.
Yes, okay. Thank you.
Well, thank you. This is Mike again, Mike Lipinski. I want to thank again my colleagues Cassie and Rachel for their presentations. In a moment, we are going to turn to Q&A from the audience. As an attorney, I don't want to be a downer here, but I want to caveat the next part of this presentation by saying that we won't be able to answer all questions. But rest assured, your question will always be taken under consideration, and we'll determine how best to respond to you. To keep that the point in mind is that, again, we may want to wait to see if we get a lot of questions around the same topic, and then we'll be able to issue in the future a frequently asked question. And in that regard, we anticipate doing more frequently asked questions and more webinars regarding those frequently asked questions. For example, we have a lot of questions about progress notes right now. So we expect to issue a frequently asked question about that and some other topics, possibly fees in the future, and then have a webinar about that. So I just wanted to caveat that. And before we jump in, I know we've received a few questions already that I've had an opportunity to skim. And again, I feel like there's still some confusion around the proactive and the test results and the preventing harm exception. So I'm going to take one more crack at it to see if I can explain everything all three of us said to you today, and we've issued through these FAQs. So again, no proactive requirement because of the for various reasons, many that what Cassie mentioned, but the scope of who this rule is applicable to. The one thing we've said and said countless times, this rule does not require you to adopt tech. So we're not asking somebody to adopt tech so they can make it immediately available to anyone. I think the question when you look at that second FAQ that was discussed today, and maybe we can go back to it, the one about test results when we talk about while there's no proactive requirement, we talk about, you know, unnecessary delays and impediments. And so if you have the technical capability, you're going to be in the situation explaining why it wasn't made available, and, you know, without delay. I think you can also read between all the FAQs and how the harm exception is structured. There is no exception for physicians to review test results before the test results are provided to a patient, except for the harm exception when it's a individualized determination as discussed by Rachel today. And it's in our FAQ, and that FAQ is a resuscitation of both the regulation and preamble of the final rule. What this does is gives, you know, puts patients in control of their information. That has been a goal of the department and this rule. A patient has a choice to look at those test results if they're, you know, up on their phone in their app, or if they're in their patient portal. It's up to them once they're there, whether they want to look at them or not. But it gives them the control over their test results. So hopefully that additional information helps explain it. I know that we're getting questions about, well, what constitutes a request? What constitutes a request when an app connects to an API? And for how long does that request last? Is it a request for every time that they, you know, is that a request every time they ask for data? Do they have to ask for the data every time they have a test? And I think we're not really in a position to answer that today. We've been considering that and considering how to answer those questions. So I expect that you'll see something from us in the future written in response to that. But again, I think I go back to saying, if your tech can provide the data now, and if you look at that FAQ and read how it said there should be no unnecessary delays or impediments to the information, we even indicate that this means that the EHI could be provided to the patient and to provider at the same time. That means if you can do it, you should be doing it. So with that, I'll stop, and I think we can go and look at what other questions we received and see if we can answer them today.
This is Grace Castro from ONC here. I've gotten several questions for the group.
Grace, you're a little bit quiet. Can you speak a little bit louder or get closer to the microphone?
Oh, sorry, is that a little better, everybody? Sorry about that.
Thank you.
No problem. Okay, so the first question that we have is for Rachel about the preventing harm exception. Does the preventing harm exception also apply to the actor who is providing care? For example, if the patient threatens the actor, can the actor block information if they feel threatened?
I will call attention to what we say in the preventing harm exception itself. It is to prevent harm. In certain circumstances, for example, if you are talking about withholding the patient's own electronic health information from the patient themselves, you would be needing to do that in order to substantially reduce a risk of harm to a patient or another natural person. And I apologize for saying that so very carefully, but I heard the question as being about a person, for example, a healthcare professional providing care, potentially being at risk of physical harm from the patient, and such a healthcare professional would probably be understood to be a natural human being. I hope that helps.
Okay, our next question is similar, also related to the harm exception. It says, in terms of state law, we are required to not share a minor's PHI related to minor consent services, such as things like family planning. Would this state law supersede the information blocking rule?
Well, I'll go ahead and take that one. I get a lot of questions along this line under the preventing harm exception, but I will note that we're talking here, and I did discuss that. We did discuss this in the preamble of the final rule, where you have a state law that prevents disclosure of certain information to certain persons. That is not something that the preventing harm exception is designed to cover, but it is a specific state law prohibition on sharing that you would want to look back at what we've said today, and Mike and Cassie have said today, about practices that are specifically required by state law not being considered information blocking or not being considered interference.
Yeah, and this is Mike, and I'll just add on to that. Cassie touched on it with the FAQ, the statute touches on it, a regulation touches on it, we touched on in the preamble of the final rule. If a law, and I guess the one caveat I'll say right away is you need to be sure you're following the specifics of the law that you're citing when you're denying access. But having said that, it's clear that you're not information blocking if you're prohibited from providing that information by a law. And we're pretty broad in how we determine required by law that prohibition from sharing the information. We talk in terms of it being state law. We talk in terms of being federal. We talk in terms of it being court decisions, administrative decisions, tribal law. So all of that, if that says that you can't provide the information, then that would not mean you meet the definition of information blocking. But again, you should be careful about how that law reads. Sometimes it's only a delay for a period of time when it comes to certain test results we've seen in certain states. So that doesn't mean you can never provide it then. So while it does provide protection from the information blocking law and definition, you need to be complying with the law that you're citing for not sharing the information.
Okay, our next question. Will ONC develop more FAQs? Are there any plans to develop more FAQs?
Yes, maybe some of you caught that, maybe some of you didn't, but before we started the Q&A here, yes, we definitely intend to issue more Q&As and then have a webinar if as necessary to discuss those Q&As or any other new information that or events that have come to light that we think that can help educate folks on information blocking. And honestly, internally, we like to talk about it as information sharing. I mean, that's what Congress wanted to do. The goal here is to really educate and improve the sharing of information. Like we try to do that through interoperability, the standards that we adopt, the health IT that we certify. So ultimately the goal is to just share the information, and our job is, the way we see it when it comes to information blocking is to educate you so that you can go about sharing that information. So as I mentioned, progress notes is something we have in the hopper, reasonable fees, helping to provide some guidance around that. So it does take some time to get questions out just to let you know that, you shouldn't be expecting them next week. We've obviously had a change in administration. New political staff are on board. We want to make sure they understand what we're doing before we issue anything and answer any of their questions or priorities before doing so. So all that means is that, yes, we will be issuing more, but probably nothing in the very near future.
Okay, and our final question for today, will there be more guidance on what constitutes a request? There seems to be several questions about this. Does ONC plan on producing any more guidance, perhaps in future FAQs, specifically with respect to what exactly is a request?
Yes, I think when we issued, I think I understand a lot of folks are multitasking, and I appreciate you attending this webinar, but Cassie mentioned this and I did too. We knew when we issued those FAQs, it would be a question about what is request. Again, I just want to emphasize, you have the technical capability to make that available as soon as possible, then you should do that. Because otherwise the question becomes from, info blocking is a fast-paced scenario. And the inquiry would be as to why the information, why was there a delay in providing the information? As to what constitutes a request in different circumstances, I had mentioned earlier, yes, we are looking at that. For example, a patient portal, an API, and we do expect to come back and provide additional guidance there.
Okay, thank you. That is all the time we have for questions today.
I want to just emphasize one more point from early on. If your question wasn't answered today, please try to submit it through that Health IT feedback portal. That helps us track that. What you need to know about that is that tracks your request. So we know we received your request, and you'll actually get notification that you received it. So I'd strongly encourage you to do that. Thank you so much for attending the presentation today. We look forward to continued engagement with you regarding information blocking and other matters that ONC is working on. So thank you again. Bye for now.